Good afternoon, everybody, and welcome to the Ceylon College of Physicians Specialty Update for the month of October. As has been the tradition this year, these are joint sessions held with one of our sister colleges for each month. And this month we are collaborating with the College of Specialists in Rheumatology and Rehabilitation in Sri Lanka. I think it's a part of the pre-congress program of their sessions. So I have with me Dr. Monica De Silva, who is President of the College of Specialists in Rheumatology and Rehabilitation of Sri Lanka. Very warm welcome to all the participants and all the panelists. I will hand over the microphone to Dr. Monica De Silva to introduce the speakers and get on with the program.
Thank you, Professor Rajapaksha. Today we have 4 speakers. Firstly, Dr. Kalum Deshapriya from Teaching Hospital, Karapidil. Second speaker is Dr. Sirinivasan Venkatachala from the UK. And third speaker, Dr. Nicola Erb from UK. And fourth speaker is Dr. Deva Sirunayaka from UK. First we will go to the first lecture by Dr. Kalum Deshapriya, consultant rheumatologist from Teaching Hospital, Karapidil. He's the past president of College of Speciality in Rheumatology and Rehabilitation, Sri Lanka, and also the immediate past president of Gold Medical Association. Dr. Kalum Deshapriya will be discussing on challenges in diagnosis of spondyloarthritis. Over to you, Kalum.
Good afternoon. I would like to thank first the presidents and the councils of the Ceylon College of Physicians and the College of Specialists in Rheumatology and Rehabilitation, Sri Lanka, to invite me to present this lecture today. So I have chosen this topic of spondyloarthritis due to many reasons, and there had been current increased interest in the field of spondyloarthritis, and it is a different type of inflammatory arthritis, and it is mainly affect the spine and of course the peripheral joints, and it is peculiar in way of incidence of sacroiliitis is much more common than any other inflammatory arthritis, and the genetic link between HLA-B27 makes it different from other inflammatory arthritis. This is a disease of enthesopathy, and the classical feature is the joint ankylosis later on, and it is seen more commoner than any other inflammatory arthritis. So I have chosen this mainly to increase the awareness of spondyloarthritis, and there had been many concerns as with regard to the diagnosis. So my aim is to discuss this as a different inflammatory arthritis. And I will be talking about challenges in the diagnosis and with current evidence and literature. And at the end, I will give some take-home messages. These are the type of patients I'm sure all of us see almost every day. How many of you are able to diagnose spondyloarthritis when one of these patients present to you with a history of back pain? For example, if you consider this man presenting to you in your clinic, 40-year-old male, episodic chronic back pain for the past 7 to 8 years, several episodes of painful swelling of the knees, and he has gone to many doctors, and as usual in our country, and there had been no regular follow-up due to, he says, due to response treatment. Whenever he feels better, he stops taking treatment till he gets the next episode. No other medical problems. He can remember once he had an injection into his right heel. That was about 5 years back. On examination, except for mild diffuse tenderness at the lower back and the mild knee effusion, an examination was unremarkable. His inflammatory markers were high, elevated, ESR 40, CRP 12, and he carries an X-ray of lumbosacral spine, which was normal. Are you diagnosed spondyloarthritis in this patient? Okay. So what is spondyloarthritis? Now, these are, how do you classify spondyloarthritis? This is a patient who has an inflammatory type of spinal pain or synovitis, that is arthritis asymmetrical arthritis or arthritis affecting predominantly the lower limbs. In addition to that, if the patient is having spondyloarthritis features, together with all these combination to make a diagnosis of spondyloarthritis. We'll discuss later on in detail about the spondyloarthritis features, either axial or peripheral spondyloarthritis. This is, I hope that this is a familiar diagram to everybody. So there are two basic varieties of spondyloarthritis. If a patient presents with spondyloarthropathy features, and if the symptoms are mainly axial, or the spine is involved, back pain, so you do the X-ray. If the X-ray shows evidence of sacroiliitis, you call them having radiographic axial spondyloarthritis. So there will be other patients who are having axial symptoms, but the X-ray, there is no evidence of sacroiliitis. You call them non-radiographic axial spondyloarthritis. But if you do MRI scan of the sacroiliac joint, there will be evidence. So you may call pre-radiographic spondyloarthritis. The other group is of course, the peripheral symptoms are predominant. There's a considerable overlap between the peripheral and the axial. You can have the mixed picture. These are the three classical differentiated varieties: psoriatic arthritis, reactive arthritis, and inflammatory bowel disease associated arthritis. So if the patient is still having spondyloarthritis features, but not differentiated into one of these, you categorize them under undifferentiated peripheral spondyloarthritis. If you follow them up, they either will develop this classical picture or may even progress to axial or ankylosing spondylitis. Therefore, it is important to follow up these patients. So there are similarities and differences between the radiographic and non-radiographic axial spondyloarthritis. Structural damage said to be high in radiographic group compared to non-radiographic group. The male to female ratio is roughly equal in non-radiographic axial spondyloarthritis, but later on, when the patient the disease progresses to radiological axial spondyloarthritis, the ratio is male to female is 3:1. So in other words, there is a higher tendency of male having possibility of developing into a more aggressive disease compared to females. The other factors are generally roughly equal: clinical presentation, age, HLA-B27 prevalence, and the patient-reported outcomes said to be similar in these two groups. What are the challenges in the diagnosis of spondyloarthritis? One main reason is it is lacking characteristic of pathognomonic clinical features. Like in rheumatoid arthritis, we do not have reliable biomarkers to diagnose spondyloarthritis. Rheumatoid factor, anti-CPA antibody, but nothing like that in spondyloarthritis. Lack of validated diagnostic criteria. And delay in referral to the rheumatology clinics, one of the major reasons attributed to the delay in diagnosis and one of the major challenge in making this diagnosis. So there are reasons, and there's a long diagnostic delay compared to other inflammatory arthritis. And this is significantly more longer in axial variety compared to peripheral spondyloarthritis. Now there are, in addition to this late presentation, long diagnostic delay, there are other factors also, challenges in relation to the interpretation of the imaging modalities. One of the key factors to diagnose spondyloarthritis, ultrasonography of enthesitis, interpretation of MRI in the case of sacroiliitis or the spine involvement. So why is it diagnostic delay important? What is diagnostic delay? It is the time taken from the onset of symptom to the diagnosis. Why is it important? Because in rheumatology, we are talking about a window of opportunity. For example, in rheumatoid arthritis, we know that the window of opportunity is 3 months. That is symptom onset to initiation of treatment. If you catch the patient during the window of opportunity, the outcome is better, and you might be able to induce a remission. The patient's complications will be less. So there's a window of opportunity for most of the other conditions, but not in spondyloarthritis. Mean delay of diagnosis was 6 to 7 years in this study, which was published early this year in the journal Rheumatology, and it was from the evidence from the 64 actual spondyloarthritis studies worldwide. It's a long diagnostic delay, 6.7 years. And this is made in the axial spine, and the peripheral spondyloarthritis delay is less, but still in years, 2.6 years. So this delay can happen in various levels, and the patient-related factors and the healthcare delivery system factors. The healthcare delivery may be the physician factors and the system problems. So these are some of the patient-related factors. The patient usually tend to ignore their symptoms, especially back pains, aches and pains. So this type of picture sometimes not coming, they don't come to take treatment in the initial stages. One major reason. Choosing the healthcare provider. And there are different variety of healthcare facilities and health systems in our country. The patients go all over, and so there is no proper way of referral system. The lack of continuity of follow-up and the interrupted care due to the response to treatment. Patient himself stop taking treatment. When they feel better, they don't come. And there are physician-related factors. There's a wide differential diagnosis for chronic back pain. If you don't diagnose inflammatory nature of back pain, you might not diagnose axial spondyloarthritis. Lack of awareness of spondyloarthritis had been one major reason in almost all the studies done in this field. So lack of awareness of spondyloarthritis features. In my presentation today, I will be mainly talking about the features of spondyloarthritis. There's a tendency to ignore the significance of back pain. When a patient comes to you, if the patient is young or a female patient, and the tendency to diagnose axial spondyloarthritis is probably less. That is one reason. The presence of peripheral, it is said that the presence of peripheral arthritis and skin psoriasis, and when you have a patient with these features and you tend to ignore the possibility of axial spondyloarthritis, there's a delay in referral to specialist care. The lack of expertise, even in the tertiary care level, for interpretation of ultrasound scanning, especially in the enthesitis, MRI of the sacroiliac joint. And there will be other factors like health system delay, no proper referral system. In our country, there may be some advantages also. Any patient can go to the specialist straight away without being referred. So that may be an advantage. But anyway, so these are some of the factors related to the health system. Long waiting lists in the clinic, availability of investigation facilities, MRI, ultrasound, HLA-B27. So I'm sure most of our rheumatology clinics, and there's a mechanism involved, and we have made sure that the waiting list for major rheumatic condition is almost zero. So we have taken every effort to see these patients in the first presentation itself. And this is quite a remarkable feature in rheumatology clinic. So why is it important to talk about diagnostic delay? It is because of the window of opportunity. In spondyloarthritis, we do not know what is the spondyloarthritis, the window of opportunity in spondyloarthritis. So if we diagnose them early, we can minimize the progression of the disease and we can reduce the health cost. So this slide summarizes the management of spondyloarthritis. So the mainstay of the first line therapy is the NSAIDs and non-pharmacological treatment. The axial manifestations, if you have patients with axial manifestation or peripheral manifestations, the first line will be NSAIDs. And if the patient is having peripheral manifestation, you have additional option of conventional standard disease-modifying drugs like sulfasalazine to treat. But in the case of axial spondyloarthritis, if you fail on NSAIDs, the next line available is the biological disease-modifying drugs. So these are the biological agents available to treat spondyloarthritis in our country. So this is the average annual cost per biological agent. It is about 1.3 million to 2.1 million for biological drugs alone. This is the health cost. It's a huge. So therefore, the correct diagnosis as early as possible is the key. So how do we make the diagnosis? Now, these are some of the classification, ASA's classification criteria. After introduction of these classification criteria, so there had been remarkable improvement in the diagnosis. So peripheral arthritis, enthesitis or dactylitis, if the patient presenting with these, and you have to look for other spondyloarthritis features to classify them as peripheral spondyloarthritis. But in the case of axial symptoms, a patient who is having inflammatory type of back pain lasting more than 3 months and age of onset of this back pain before the age of 45 years. This is important. You are not going to diagnose axial spondyloarthritis if the back pain started, say around 50, 60, you are not going to diagnose that. So a onset of back pain should be before the age of 45 years. Together with these other spondyloarthritis features, you make a classification or you diagnose axial spondyloarthritis and with the help of imaging. So what are these spondyloarthritis features? Like rheumatoid, how do we diagnose rheumatoid arthritis? We look for features of rheumatoid arthritis. This is the classical presentation for rheumatoid. The joint involvement is bilateral, symmetrical, hand involvement is more commoner, small joints affects more commoner than large joints, and the polyarticular presentation. So if you have a patient like this, you are not going to diagnose spondyloarthritis. It is very likely to be rheumatoid arthritis. Similarly, so you have to look for features of spondyloarthritis. So what are the spondyloarthritis features? The inflammatory type of back pain. That is the age of onset of back pain before 40 or 45 years, insidious onset, improvement with exercise, no improvement with rest, pain at night or early morning. So if you have these features, whenever you get a patient with back pain, look for evidence of inflammatory back pain. So this is another very helpful feature, alternating type of buttock pain. Patient experiences pain in one buttock, it completely goes off and experiences the pain on the other buttock. So that is a classical feature of early sacroiliitis. It is not that the patient do not have these symptoms. The problem is we do not inquire into these important symptoms. This is another important clinical feature. We know how difficult to treat the inflammatory arthritis pain with NSAIDs. For example, rheumatoid arthritis. However much we give NSAIDs, it is difficult to treat this pain unless we give steroids or get the disease under control with biological disease-modifying drugs. But in the case of spondyloarthritis, classically, there's a dramatic improvement of their symptoms within 24 to 48 hours if you give a full dose of NSAID. So if you inquire into these features, you will get these very important classical features. Then arthritis. It is just the opposite of rheumatoid arthritis. It is an asymmetrical oligoarthritis, predominantly in the lower limbs. Large joints affects more than the small joints. So this is the classical presentation of arthritis in spondyloarthritis. And look for evidence of enthesitis, look for evidence of dactylitis. It may not be at this presentation, maybe even in the past history of dactylitis, enthesitis is important. And look for specific extraskeletal manifestations like psoriasis, inflammatory bowel disease, or uveitis. And look for preceding infections, it's another spondyloarthritic feature. Positive family history of these diseases, first degree or second degree relative having ankylosing spondylitis, psoriasis, uveitis, reactive arthritis, and inflammatory bowel disease. And then elevated inflammatory markers like CRP, the presence of HLA-B27. So these are the other features that you will look for. So once you detect the spondyloarthritis features or suspect that the patient is having spondyloarthritis, it's a matter of you applying these algorithm criteria to diagnose spondyloarthritis. So you don't have to worry about these algorithms, remembering these things, and if you suspect, refer the patient to the rheumatology clinic. But what is this algorithm basically says is, higher the number of spondyloarthritis features, higher the possibility of them having spondyloarthritis. Lesser number of features, you need additional investigations to diagnose spondyloarthritis, at least in the case of axial spondyloarthritis, HLA-B27 or MRI scan of the sacroiliac joints. Right. There are other features also. There are sex-specific differences in spondyloarthritis. Women generally experience longer time to diagnose. There's a median delay is much more longer in females compared to males. And very severe disease is seen in males compared to females. The significant poor response to biological agents in females. These are some of the features. So in the clinical presentation, the males classically present with the axial spine involvement with the lower back involvement predominantly. In the case of female, the spine is mainly not the lower, the spine is the upper spine, the cervical spine. They will have, rather than the stiff, stiffness of the sacroiliac joint or the spine, they will present with diffuse type of pelvic pain. Peripheral symptoms will be more prominent, like enthesitis and arthritis. They will have depression, anxiety, and this sort of features. Therefore, overall, the diagnosis of spondyloarthritis in females is difficult compared to males. If we come back to our patients now, can we diagnose spondyloarthritis in this patient? So this is a patient who is 44-year-old and presenting with chronic back pain. So if you elicit the inflammatory nature in this back pain, you will diagnose one spondyloarthritic feature. Age of onset is before the age of 45 and inflammatory back pain. If you carefully examine the patient looking for evidence of arthritis or synovitis, so that is another feature, painful swelling of the right knee, so lower limb affection, so that is a feature of spondyloarthritis. Now he has taken treatment from many doctors and no regular follow-up, he says, due to response to treatment. If you inquire into this in detail and if you take a detailed history, whether this response really means it's a dramatic response to NSAID or not, that itself is a feature of spondyloarthritis. If the patient says in positive, yes, I responded very well to NSAIDs, that is a clue to suspect spondyloarthritis. So he remember having an injection, very likely that his plantar fascia have been injected in the past. So as I said, it is not necessary for him to have all these clinical features at this particular presentation, maybe in the past also important. In your examination, here the tenderness at the lower back. If you execute your clinical examination correctly, if you test your sacroiliac joint correctly, you will detect sacroiliitis. And there was knee effusion, so lower limb involvement, that is another clinical feature. His inflammatory markers were high, another spondyloarthritic feature. And he carries a lumbosacral spine X-ray, but probably not the type of X-ray that he should have taken, so the X-ray of the sacroiliac joint. If the patient shows evidence of sacroiliitis, so that itself gives the diagnosis, and if it is negative, you have to go for the MRI scan of the sacroiliac joints. So if you take this patient, so he has a lot of spondyloarthritic features if you carefully take the history. So you can diagnose axial or peripheral spondyloarthritis depending on the type of involvement. So this is a man, probably almost every day we are seeing these type of patients. If we pay special attention with a view of trying to diagnose spondyloarthritis, we will diagnose these patients. So what are the take-home messages? It is important to remember that there's a very long diagnostic delay. Not only that, and we do not know the window of opportunity in the case of spondyloarthritis. So we are dealing with a difficult clinical scenario. So awareness of spondyloarthritis features is probably the key to early diagnosis. And special attention should be paid to, especially in the case of axial spondyloarthritis, in 3 groups of patients. Young patients with spondyloarthritic feature symptoms, female patients, and patients who are having psoriasis or peripheral arthritis. These groups said to be difficult diagnostic problems. Early rheumatology referral is important to plan management and further evaluation. Thank you.
Dr. Deshapriya for very interesting presentation. Q&A session will be at the end of all 4 presentations. Let us move to second presentation by Dr. Srinivasan Venkatachala. He is a consultant rheumatologist, Canocken Wolverhampton Rheumatology Centre, UK, honorary senior lecturer, Edgehill University, UK, and also honorary treasurer in the UK Rheumatology Forum. His special interests include osteoporosis and clinical trials of treatment of patients with arthritis. Dr. Venkatachala will speak on updating osteoporosis. Over to you, Dr. Venkatachala.
Thank you very much, Dr. Monica De Silva, for the kind opportunity to talk to you. I'm a consultant rheumatologist, as mentioned, in the West Midlands and north of Birmingham at the Canocken Wolverhampton Rheumatology Centre, and have a special interest in osteoporosis. I'm going to talk to you about the size of the problem in Asia, and particularly in Sri Lanka, and touch upon fracture risk assessment and what are the new things that are coming in fracture risk assessment, and especially when you don't have easy access to bone density scans, how you can do clinically, and to highlight the importance of vertebral fractures, which are common in Asia as well, and complete with the treatment options available and the side effects. All of you are familiar with this slide. This is a normal bone under the microscope, and this is the osteoporotic bone, like holes in the bone. And this has got less trabecular connectivity, and easily somebody can break a bone with minimal trauma. And we want to prevent these fractures. So this is the slide showing the difference between men and women, and at different ages, the incidence of fractures. Though it's almost 15 years old, it's still valid. Women have more fractures than men. And in the early postmenopausal years, when the reflexes are good, wrist fractures are more common. But later in life, when they fall on the hip and the reflexes are not good, hip fractures tend. And this is a picture about radiological vertebral fractures, which are picked up in studies. And only 1 in 10 of these patients come for clinical attention, vertebral fractures. And there is a second peak of wrist fractures later in life. What is the burden in Asia? We are expecting an increased risk of osteoporotic fractures, especially hip fractures, by 2050. You all heard about the net zero of climate change by 2050, and this is going to be a huge time bomb. This is because of the aging population, which is increasing in Asia, and urbanization, people moving from rural areas, and decreased physical activity and changes to the nutrition. This is a slide again, the projection from 30 years ago, which is coming true now. So increased risk of hip fractures in 2050 in Asia. In the last 30 years, the hip fractures have gone by 2 to 3 times more. And in the next 30 years, they are likely to increase another 3 times. And we all need to be prepared as physicians to address this risk and how we can minimize this. So this is the regional audit of Asia Pacific region from the International Osteoporosis Foundation. Though it's almost 8 years old, it's still valid, though there might be some changes. Now I'll just highlight the figures for Sri Lanka. In 2013, the life expectancy was 76 years and the projected one to go to 82 years. And people above the age of 50 are going to go to 38%. So as people are living longer and multiple morbidities and increased risk of hip fractures. So this is a study by Dr. Lekamatham and colleagues published last year in Archives of Osteoporosis, looking at fracture risk, hip fractures in Sri Lanka. When you standardize for 100,000 person years, it is not as high as in North America or Scandinavia or Northern Europe. But you're currently seeing about 4,000 hip fractures a year and about 10 per day. And in 2051, it's going to increase to 12,000, 3.3 times increase per day. And I think for a country for the size of Sri Lanka, when the population is going to be 24 million, this is a significant increase. And I think clinical risk factor prediction, all of you should be familiar with FRAX, which is from the WHO Center for Osteoporosis in Sheffield, developed by John Cannis, Eugene McCloskey and colleagues. And this is open access, and you can easily access that. And they've got country-specific fracture prediction. And if you just look at the prediction for Sri Lanka, so you go into the calculation tool, look at the clinical risk factors, which all of you have got access to: age, sex, weight, height, previous fracture. If the parent has fractured a hip before the age of 75, if they are current smokers, are they on steroids, if they have rheumatoid arthritis. These are 9 clinical factors which all of you got access to when you're seeing the patient. And if you probe a bit in the history, you get secondary osteoporosis. Have they got type 1 diabetes mellitus? Have they gone through the change very early? Have they got osteogenesis imperfecta, any other malabsorption problem? Are they drinking more alcohol? Then if you got access to bone density, you can incorporate that. But without bone density, if you just apply the Sri Lankan one, so we can get a risk, a major osteoporotic risk in the next 10 years of 8% for this lady who is 65 years old and weighs 70 kg and the height is 165, and she's got rheumatoid arthritis, which you'll see in your clinics. What is the risk of hip fracture in the next 10 years? 2.3. Unfortunately, it's been available for 10 years, but less than 20,000 people have accessed, 20,000 patients have been accessed with this. And we all need to use this more to try and decide on treatment. When do we decide about intervention? If you're in America, they've got a fixed intervention threshold. If the major osteoporotic fracture is 20% and hip fracture is 3%, they think it's intervention. In UK, we've got the National Osteoporosis Guideline Group, which has got age-specific intervention. But Dr. Lekamatham and colleagues have worked out the intervention thresholds in Sri Lanka. At 50, major osteoporotic fracture risk of 2.7 and hip fracture of 0.4. And at 80, it is 18 and 7.1. It may be difficult to try and remember all this, but we can simplify that with a hybrid method. If you're less than 70, 6% major osteoporotic fracture in the next 10 years, or 2% hip fracture. 15 and 5 at 70, 18 and 7 at about 80. So this is easily implementable. And if somebody's got such a high fracture risk, you need to consider treatment. And you can decide clearly the people in the red need treatment, people in the green just need lifestyle intervention and optimizing calcium and vitamin D. And the people in the middle might use the limited bone density scans available to decide on treatment. Moving on, FRAX is going to modify some of the things with the new evidence available from studies from Iceland. So we've got what's called a very high risk threshold. People who have had a recent fracture, people who have had multiple fractures, very low bone density, and people who are fracturing on treatment. And how does this change the paradigm of treatment? If you got a low risk, we see that we can optimize treatment, lifestyle, hormone replacement. High risk is the current option of anti-resorptives. And very high risk patients, we are moving on to using anabolic agents early, like teriparatide. And we also have romosozumab, which I'll talk about later, and then use anti-resorptives later, and even consider local treatment, local bone enhancing treatment. What is imminent fracture risk? There is a highest risk of future fracture in the first 2 years after a sentinel fracture. It's higher in the young age groups, high after a vertebral fracture compared to a wrist fracture. And the FRAX is going to come up with a modification factor to reflect a correction of twofold or threefold in the major osteoporotic fracture. As you can see from this Icelandic study, most people fracture in the first 6 months to 12 months to 24 months, and the fracture incidence becomes less remotely after the index fracture. And this also changes with age. The younger people in the first 6 to 24 months have a higher risk of fracture compared to later in life. And if you look at 5 years, the fracture risk goes down. And we had to deal with our long waiting list during the pandemic and infection control. We couldn't do DEXA scans for everybody. So we had to prioritize patients who will really benefit from DEXA scan. And we published this in Osteoporosis International. So people at higher risk, we can intervene without a DEXA scan. People at a low risk may not need a scan. And people in the intermediate risk, you can use the limited resources. Fracture license services are really making a difference. If you catch patients after the first wrist fracture and intervene, then you could prevent the hip fractures. And evidence from Glasgow, the fracture license service capital in UK, and it's been sort of reproduced in other areas. So International Osteoporosis Foundation have invested a lot in this Capture the Fracture initiative. And I was just looking at it in June 2021, there is one center in Gale in Sri Lanka, which has got a fracture license service. And we need to have more of these to try and prevent more fractures. Vertebral fractures have been a Cinderella in osteoporosis, but they are the most common osteoporotic fracture, and 70% remain undiagnosed. If you take 55% of older women with a hip fracture, they've already had a prior vertebral fracture. It is an opportunity to try and intervene. But I think there is no definite radiological reporting, and only few are acted upon even if they're reported. There is ambiguity in the reports. They say deformity or crush fracture, or they don't call it a fracture all the time. But why are vertebral fractures important? They increase the risk of subsequent fracture, 5-fold, and 2-fold risk of hip fracture. And 1 in 5 women who have a vertebral fracture will have another fracture within a year. And if they have more vertebral fractures at baseline, the risk is exponential. What is the health impact? We know that they are strong predictors of future fractures. If left untreated, they can cause a lot of morbidity, and they include additional visits, 14 additional visits to the primary care physician locally after the year of fracture. And identification provides an opportunity to intervene. What happens to the patient? If you could see this lady, slowly with multiple vertebral fractures, it's a cascade effect. Losing height, bulging of the abdomen, and you can clinically see as a decrease in the space between the rib margin, the costal margin, and the iliac crest. Acute and chronic pain, less body image, breathing difficulties, depression, reflex and GI symptoms, difficulty in managing activities of daily living, and the need to use a walking aid, losing independence, and it also increases mortality. This is a semi-quantitative classification by Janant and others from America. So this is the commonest one, anterior wedging, decrease in height of the body by 25%, up to 40% is moderate, more than 40% is severe. It could be biconcave, or it could be a crush fracture involving the posterior elements. We were involved in the Royal College of Radiology audit of CT chest, abdomen, and pelvis cross-sectional, done in many hospitals by physicians over a 3-week period in more than 70-year-old patients. The images are reformatted and incidental fractures had to be reported, and the vertebral fractures were graded by Janant's method. We excluded severe trauma and cancer. Electronic records were reviewed to look at the underlying problems. Out of the 105 scans, 14 were excluded. In the remaining 91, 1 in 5 had osteoporotic vertebral fracture, but none of the reports included a recommendation for further intervention. We worked on this under-reporting of vertebral fractures, worked with our radiologists, and to change the reporting, and they link it now to the fracture license service. And over the last year, we've had 100 new referrals for vertebral fractures in our local unit. This is a powerful predictor of future fractures and increasing awareness, and which could be done by physicians like you in your country. This underdiagnosed vertebral fractures is a worldwide problem. Global rate is about 34%. And I think we can all work on to improve the identification of vertebral fractures. Steroids, commonly used by physicians for many indications, they also increase the risk of vertebral fractures 1.5 times, even at a lower dose, from the study, which is more than 20 years old, from the General Practice Research Database. But fortunately, if you intervene after coming off steroids, the fracture risk goes down and we could stop the treatment. This is the American College of Clinical Endocrinology guidelines for postmenopausal osteoporosis. And this is to just highlight this very high risk I highlighted earlier. Recurrent recent fractures, fractures in approved therapy, multiple fractures, very low T-score, a history of injurious falls, and very high FRAX score for the Western population. We think about anabolics here. And these are high-risk patients who do not have the criteria for the very high risk. Moving on to treatment, bisphosphonates are the mainstay of therapy because they're generic, they're easily available. Oral bisphosphonates are preferred, but they can work around for a longer time. And intravenous zoledronate, I understand, is available in Sri Lanka. And that may be also a good option for people who can't comply with treatment, but we need to be careful with patients with renal impairment. The challenge of oral bisphosphonates is compliance. Because of the complex dosing, fear of side effects, and it's like any other chronic condition, people may not continue with the treatment. It's only 50% or less continue it after 1 year. And if they're not going to take it, it's lack of efficacy and reduces the cost effectiveness. And there's a study which shows that people who complied, the fracture risk decreased, and people who didn't comply, it carried on. Denosumab is an option. In our unit, we find we have a low threshold for switching patients to intravenous zoledronate or denosumab because of the high compliance. This may not be widely available in Sri Lanka. It's useful as an option in patients who can't have intravenous zoledronate. If they have renal insufficiency or eGFR below 30 or 35, we can use it up to 15, but the risk of hypercalcemia is high. And one caution is if you delay the injection for more than 4 weeks, there's increased risk of bone loss and rebound fractures in 1 in 10 patients. This risk is higher if denosumab is being used for more than 2 years. For these patients, there are randomized controlled trials being done of using oral bisphosphonates and or zoledronate maybe 6 monthly, guided by bone turnover markers. Teriparatide is an anabolic agent. Again, I understand it's not widely available, but become available with the availability of biosimilars now. Daily injection for up to 24 months. We currently use it as third line in UK, but it might change with the evidence coming on very high-risk patients. There's a new kid on the block, romosozumab, an anti-sclerostin antibody. We were involved in the clinical trials for this medicine. It's a monthly injection for 12 months, but a caution in people with cardiovascular risk, MI or stroke. But it increases bone density even more than teriparatide. What about the complications? Bisphosphonates have adverse events like osteonecrosis of the jaw between 1 in 10,000 to 1 in 20,000 patients and atypical femoral fractures. We will see that in the next few slides. But the risk of a typical osteoporotic fracture is around 1 in 100, but this risk is less common. But because of the fear of the side effects, people don't take the treatment and still have hip and vertebral fractures. But if you take the treatment effectively, then they can reduce the fracture. Osteonecrosis of the jaw, phossy jaw. This caused scare stories in newspapers, and the treatment compliance in America with this treatment has gone down in the last 10 years because of these scare stories. But this is more common in advanced cancer, where they use intravenous zoledronate almost monthly or quarterly. It's 1 in 10,000 to 1 in 100,000. And if they have poor dental hygiene or they're having major dental procedures, somebody on steroids or vitamin D insufficiency. But we need to counsel the patients and check them regularly. What is this risk in a context? This is a risk in sort of 100,000 people per year. The risk of a fracture is 2,600. Hip fracture, nearly 400. The risk of osteonecrosis of the jaw is just slightly higher than death by lightning strike there. So we need to put that in perspective to our patients. It is even rarer than anaphylaxis many times. Just to finish with a case, this is an 84-year-old lady we recently saw in the last year. She's been on steroids for a long time for allergic bronchopulmonary aspergillosis from a chest physician. She had multiple comorbidities, and she was given alendronate or Rytely for bone protection as she was on steroids. But she took it for more than 15 years, a rare patient complying. But she presented to our emergency with a right hip pain, and lo and behold, she had an atypical femoral fracture. This was treated with intramedullary nailing, but on subsequent X-rays, she found she had an incomplete fracture on the left side, which was managed conservatively. This is the atypical fracture. It's seen in 1 out of 1,000 women who have bisphosphonates for more than 3 years. The classical prodrome is insidious thigh pain. So any patient you put on a bisphosphonate, you need to ask them, educate them about this rare side effect and review them. This is seen in patients in advanced cancer treatment as well. Usually occur after little or no trauma, and they are below the trochanter. We don't understand the mechanism fully, but it's related to low bone turnover. The American Society of Bone and Mineral Research have got effective criteria. As I said, it's located in the shaft, and to have 4 of the 5 following major fractures without trauma. And I'll show that in the next X-ray. Short oblique configuration. It's not comminuted. It has got a medial spiking. There is diffuse cortical thickening, and you can see the lateral beaking. So at least having 4 of the 5 features. But there is a rapid decline after you stop them. So say after you stop the bisphosphonates. As you can see, the study from Denmark, which looked at 10,000 person years, and the longer you take it, more than 7 years, the risk of atypical fractures goes up. After you stop it, the risk dramatically falls down. But it's important to know that there are people who don't have any bisphosphonates can also have atypical femoral fractures. And we need to think about low alkaline phosphatase in these patients. This is a study which has shown that the Asian patients in America, this is the clinical risk, clinical fractures prevented, hip fractures prevented, and the number of atypical fractures. This is in white Caucasians, and this is in Hispanics. There's increased risk of atypical femoral fractures, and the risk-benefit ratio is less in Asians, which we need to take note of. Younger age, Asian ethnicity, higher BMI, steroids, rheumatoid arthritis, other drugs like SSRIs or PPIs, and the femoral geometry can contribute. So 50% of patients were Asians with atypical femoral fractures. There's an almost 7-fold increased risk of this acid. This has been reproduced in studies in Singapore and Sweden, and people are working on this. And this particular study published in Bone last year from Nguyen shows Southeast Asians are slightly higher. So we need to take this into account. Southern Asians are also higher risk. So how do we manage these ones? Withholding bisphosphonates will reduce the risk after a few months, and atypical fractures may be less common with Denosumab as it doesn't hang around in the bone. People have used teriparatide anecdotally, but a randomized controlled trial has not shown it to improve atypical fractures. And incomplete atypical fractures did not progress to complete on stopping the bisphosphonate. And we can't prevent the fracture on the other side with teriparatide. This is an important slide to try and sort of see what do we do with patients on long-term bisphosphonates. This is the guidance in UK and America. If they want 3 years of zoledronic acid or 5 years in oral bisphosphonate, you stop and review. Repeat the bone density scan, reassess the fracture risk, and people have vertebral fractures, hip fractures, repeated fractures, continue the treatment after checking adherence. Or if their BMD is below -2.5, this is from the FLEX extension study, they're at a higher risk of future fracture, you continue the treatment. Use the opportunity to switch somebody from an oral bisphosphonate to IV bisphosphonate here. But if they're being good, if they've had no fractures, BMD is improved, T-score is above -2.5, give them a break. Just continue calcium and vitamin D and reassess fracture risk. But in the Asians, we might have to educate our patients and possibly do it after 2 years of zoledronic acid or even 3 years of bisphosphonates because of the higher risk of atypical fractures. What is the future? We expect there should be wider availability of fracture license services with the Capture the Fracture program of the International Osteoporosis Foundation. There are new techniques for diagnosis are coming up. Sarcopenia, I've not touched upon this, but falls prevention and muscle strength building. Drugs for aging are going to bring up new sort of therapies for osteoporosis. To conclude, hope I've convinced there is a significant increased risk in osteoporotic fractures in the next 30 years. Timely intervention is essential for imminent fracture risk and very high fracture risk. And we need to optimally use the available therapies, what we have, and periodic review of patients and long-term bisphosphonates. Thank you very much for the opportunity.
Thank you very much, Dr. Venkatachana, for illustrating osteoporosis management very clearly. Q&A session will be at the end of the whole presentation. And let us move to the next presentation. Next speaker is Dr. Nicola Erb, consultant rheumatologist and honorary senior lecturer in rheumatology, Data Group, NHS Foundation Trust. Dr. Nicola's special interests include SLE. Dr. Nicola Erb to speak on systemic lupus erythematosus and infection, particularly in relation to COVID-19. Over to you, Nicola.
Good afternoon, ladies and gentlemen. Thank you very much for asking me to present at your meeting this year. I'm just sorry that I can't be with you in person this time. So I'm going to talk about systemic lupus erythematosus, infection, and COVID-19. So I'm going to start with a case presentation of a lady who presented in the last 18 months. I'll talk generally around infection and lupus, then COVID-19 and lupus, and then I'll touch on COVID-19 vaccination and immunosuppression. So if we start with the case, this lady, Mrs. SM, was a 47-year-old lady who'd been diagnosed with lupus at the age of 34, and she had fairly typical lupus at that point with inflammatory arthritis, serositis, ANA and double-stranded DNA antibody positive. She'd been stable for a number of years on azathioprine 200 milligrams daily in divided doses and low-dose prednisolone 5 milligrams daily alongside hydroxychloroquine. Things started to change in May of last year when she had a deterioration in her symptoms. She had increasing fatigue, she developed joint pain and some peripheral edema. And the blood test results at that time showed a strongly positive ANA, a rising titer of double-stranded DNA antibodies, and a low C3 and C4. Her ESR was significantly elevated with a moderately elevated CRP. Her albumin creatinine ratio at that time was elevated at 215, and her serum albumin was low at 18. So it was felt that she had had a systemic and a renal relapse, and she went on to have a renal biopsy that showed evidence of vasculitic glomerulonephritis with diffuse proliferative lesions in keeping with class 4A disease. So at this point in time, the UK was currently on the tail of the first wave of the COVID-19 pandemic infections. And it was really uncertain at this time as to the risk posed by immunosuppressants and severe COVID-19 disease. So it's a little bit difficult to determine what treatment we should go for next in this lady. But after discussion, it was decided to increase her prednisolone up to 30 milligrams daily and to switch her azathioprine over to mycophenolate mofetil, increasing the MMF up to 1 gram BD. And she did have some improvement in her symptoms, and her proteinuria did increase, coming down to 30. However, improvement was short-lived, and by September, she was starting to deteriorate again. She had increased proteinuria once more, with an ACR now rising to 250. She developed a new rash, and she had shortness of breath, with the chest X-ray showing some evidence of fluid overload and small bilateral pleural effusions. So by this time, she was on 1 gram TDS of MMF. Her prednisolone had been increased up to 20 milligrams daily. She continued on the hydroxychloroquine. She was requiring ramipril and doxazosin for her blood pressure, and atorvastatin for hypercholesterolemia. So what would be our next steps in treatment here? We were really uncertain whether to go for cyclophosphamide. This is a tried and tested treatment for lupus nephritis, but it is significantly immunosuppressive. Will we go for rituximab? So this lady has failed on mycophenolate mofetil and has ongoing serious active disease, so would be eligible for rituximab according to UK protocols. Or should we try tacrolimus? So I don't have much experience of use of tacrolimus, but there are studies showing that it is helpful, particularly in renal lupus, often in combination with mycophenolate mofetil. So at this point in time, we were at the tail of the UK first wave of COVID-19 infections, and COVID-19 cases were actually low in the UK. So a decision made was to treat this lady with rituximab. So in November, she received 2 intravenous rituximab treatments 2 weeks apart. Her mycophenolate was reduced down to 1 gram BD, and her prednisolone reduced down to 10 milligrams daily. And over the next 2 to 3 months, she did have a gradual improvement in symptoms, with a reduction in her systemic symptoms and improvement in her shortness of breath. Her ACR and double-stranded DNA antibody levels fell, and her C3 and C4 rose. So she had both a clinical and a serological improvement in her symptoms. And then in February and April 2021, she received both doses of the AstraZeneca COVID-19 vaccines. And we were lucky in the UK that we had a very early rollout of vaccination. And as she was considered clinically extremely vulnerable, she was called for vaccination in one of those early waves. Unfortunately, in June, things started to deteriorate. She presented to clinic with mild shortness of breath. She had no additional symptoms to suggest active SLE, and her urine dipstick showed minimal proteinuria. A nasal swab from that day did show positive SARS-CoV-2 RNA detected, indicating that she had been infected with COVID-19. She had a respiratory review, and despite only feeling mildly short of breath, she was hypoxic with oxygen saturations of 92% on room air. She was therefore admitted. She was commenced on dexamethasone, 6 milligrams daily, as was protocol, thromboprophylaxis, and a mycophenolate was paused. Unfortunately, she had a rapid deterioration, and this was her chest X-ray around 4 days post-admission. And as you can see, there's these fluffy infiltrates throughout both lung fields, which are indicative of COVID pneumonitis. She received intravenous tocilizumab, as was protocol for severe disease. She had inotrope support, but unfortunately developed multi-organ failure and died approximately 10 days post-admission. So this was a very sad case of a lady with active lupus who was immunosuppressed and subsequently succumbed to COVID-19 infection. So I'm going to go on to talk around infection in lupus generally, and then I'll move on to COVID-19. So this is a meta-analysis of trials that have reported on infection rates in lupus, and this was pre-COVID era. So it found that infections are a major cause of morbidity and mortality in lupus, with around 50% of patients experiencing a severe infection, and a quarter of those will require hospitalization. Infection still accounts for around 25 to 50% of overall mortality in SLE. And over the last 20 years, it's been shown that serious rates of serious infection have been rising in the lupus cohorts. So why are lupus patients more at risk of infection? So this is a diagram of the immunopathology of lupus, and we know that there's abnormalities in both the innate and the adaptive immune response that lead to the development of autoimmunity. And a number of these abnormalities also confer an increased risk of infection. So we know that there are abnormalities in antigen presenting between dendritic cells and T cells. We know that there's abnormalities in the subsets of T cells and B cells that are produced in lupus patients that also increase the risk of infection. We know that complement levels are important, so complement deficiencies predispose to autoimmunity and also increase infection rates. And then abnormalities in macrophages and mononuclear cells can also increase the risk of infection and the development of autoimmunity. So there are a number of reasons in the immunopathology of lupus as to why these patients are also more at risk of infection. There's also a number of individual risk factors in lupus patients that predispose them to infection. So advancing age has been found to be a risk factor for infection. And we think this is why the rates of infection are actually rising in lupus cohorts. So as lupus patients are surviving longer, the age of the cohorts is increasing, and this then increases the risk of infection. Active disease will increase the risk of infections, however you want to measure that, but particularly if you have a high SLEDAI or if you have a low C3. If you've had hematological involvement, so particularly if you've had low hemoglobin, low total white count or platelets, whether you've had previous nephritis or if you have serositis, will all predispose you to infection. So if we move on to the immunosuppressive drugs and infection in lupus, so the data is actually quite difficult to interpret here because lupus patients already have a number of risk factors why they may be developing infection. They're often on multiple drugs and those drugs may change. So it's quite difficult to determine which each individual drug, the risk that it imposes on increasing your risk of infection. What we do know is the majority are linked with an increased risk. So mycophenolate, azathioprine, and methotrexate have all been linked with an increased risk. However, we know that hydroxychloroquine is protective. So cohorts of patients who are on hydroxychloroquine actually have a lower rates of infection than those that are not. Now we know that hydroxychloroquine does have a degree of an antiviral, antibacterial and anti-helminthic effect. So this is probably what's protecting the lupus patients who are on long-term hydroxychloroquine. Studies have also shown that tacrolimus has a minimal effect on increasing infection rates, even when it's used in combination with mycophenolate. And then studies have linked a number of drugs to the risk of developing serious infection. So the use of corticosteroids, the use of cyclophosphamide, and the use of rituximab for 6 months post-treatment with rituximab, or if you have more than 3 cycles. And this is a graph showing the relationship between corticosteroids and infection. So if you're on low-dose corticosteroids, less than 7.5 milligrams daily, this doesn't seem to increase your risk of developing infection. However, if you're on more than 7.5 milligrams, your adjusted odds ratio of developing infection increases to 1.34. And if you're on more than 30 milligrams, that almost doubles up to 2.14. So corticosteroid doses are important with regard to infection rates. So what organisms are lupus patients tending to get infected with? So we know that the type of organism that they are infected with will vary according to environmental prevalence, so that will vary at different areas around the world. But around 80% of infections are bacterial, with 10% being viral and 2% being fungal. So this is a nice Korean cohort that reported a couple of years ago, and the results are very similar to a Spanish cohort that was also reported recently. So in this cohort, they had 120 cases of infection. The vast majority of them were bacterial infections, and they were the infections that you would expect in the general population as well. So upper respiratory tract infections, pneumonia, urinary tract infections, GI infections, cellulitis. And the organisms that they're infected with, again, are ones that we see commonly within the general population. Mycobacterium infection was relatively high in this cohort at 7, and we'll talk a bit more about Mycobacterium infection in the next slide. Fungal infection only occurred in 3, and they only had 1 viral infection, which was varicella zoster. And varicella zoster is the commonest viral infection that you will find in lupus patients. So I'll just talk quickly about Mycobacterium infection in lupus. So multiple studies have shown that there are increased rates of TB infection in lupus patients. So in endemic areas, the incidence of TB infection is around 5 to 7%, with latent TB incidence being up to 25%. We also know that TB in lupus tends to occur more frequently in the extrapulmonary sites, with the skin, the gut, and the joints being the most common places. Patients are also at risk of non-tuberculous Mycobacterium infection, what was previously called atypical Mycobacterium. So it's recommended that if you're in an endemic area, that you should consider skin testing or T-spot testing patients, particularly if you're going to immunosuppress them, and consider prophylactic treatment for their TB. And certainly in the UK, if we're going to use biologics, we will do a T-spot test on all patients and a chest X-ray, checking to see if there's evidence of latent TB, and arrange for treatment if there is prior to the biologic therapy. And a major risk factor for the development of Mycobacterium TB is the corticosteroids. So I'm just going to move on to talk about COVID-19 and lupus. So I took these figures from one of the world databases on COVID infections at the beginning of October. And at that time, there had been 237 million cases of COVID-19 reported. And these are only cases that have tested positive, so is a big underestimate of the actual number of cases that have occurred worldwide. And at that point, there had been 4.8 million deaths from COVID reported. So the UK was hit hard with two major waves of infection. The first one in March, April of 2020, and the second one from November 2020 to March 2021. We have actually got a third wave going on now, with around 40,000 cases a day, but thankfully the vaccination rates within the UK have kept the death rates low at the present. So this was the graph of deaths that occurred throughout the UK, and as we can see, there was a peak in the April-May time with death rates occurring over 1,000 for a number of days, and then again in the January, February, March time with high numbers of deaths occurring. So I think when the realization that the COVID-19 was going to be a pandemic affecting the whole world became evident, that rheumatologists all around the world started to worry about their patients who were immunosuppressed, and also their lupus patients were already more at risk of infection. And how much of a problem would COVID-19 be in this group of patients? So there were a couple of things that we felt may protect the lupus patients from severe COVID-19 disease. The fact that they're largely a female cohort, and we knew fairly early that severe COVID-19 was more prominent in male patients. Also in lupus patients, the type of inflammation they get is largely driven by type 1 interferons. Type 1 interferons do have an antiviral action, so it was postulated that this might help prevent severe COVID-19 in this group of patients. However, we knew there were a number of susceptibility factors. So patients were using corticosteroids, there was a large use of immunosuppressants, and a proportion of patients would have renal disease, and also the ethnic grouping in lupus patients. So we know that lupus is more severe in the Afro-Caribbean, African-American population, and some Asian populations, and these also were groups that were more at risk of severe COVID-19. So in the UK, clinically vulnerable patients were advised to shield by the UK government, and this basically involved remaining at home for a number of months, not having visitors to the house, being very careful of deliveries, coming into the house, etc. And what we know is that shielding was very effective in reducing infection in vulnerable groups. So we didn't know for a long period of time whether COVID-19 was going to be more severe in lupus patients, because actually the public health measures that were put into place reduced the infection in that group to very low levels. But now multiple observational studies are reporting on COVID-19 in lupus. And what they're tending to show is that the morbidity and mortality in lupus patients mirrors the general population. So this tends to occur in the older age group, male sex, those with renal disease, cardiac disease, and certain ethnic groupings. Hydroxychloroquine doesn't appear to have a protective effect in either preventing the development of symptomatic COVID or the development of serious disease. Now, as we all know, hydroxychloroquine's had a checkered history with regard to COVID-19. Initially, it was thought that it may be helpful, and actually supplies became quite short for our patients as they were diverted to be used for prophylaxis for COVID and for treatment of symptomatic disease. But studies in the general population didn't find it was of benefit, and now that seems to be borne out in the lupus populations. There doesn't appear to be a protective effect. And interestingly, immunosuppressive drugs didn't appear to affect the outcome from COVID infection, although there is data for an adverse effect with both corticosteroids and some emerging evidence for rituximab. So this is one of the big cohorts in Europe that has reported recently. So this involved all rheumatology patients. So it's not just lupus patients, but across the whole spectrum of rheumatological disease. And this was looking at rates of COVID-19 and hospitalization. And these are adjusted odds ratios. And as you can see, those traditional risk factors that we knew from the general population increased your risk of severe COVID hold true in the rheumatoid population. So the older age, hypertension, lung disease, diabetes, and renal impairment. DMARDs did not seem to increase your risk of serious disease. And if anything, biologic DMARDs, and particularly TNFs, may reduce your risk of serious disease. With corticosteroids, a dose of between 1 to 10 milligrams daily did not appear to have an effect on your risk of serious infection. However, above 10 milligrams, this did increase your risk of severe COVID-19 and hospitalization. So what I would say around immunosuppressants of COVID-19 is that timing is everything. So it doesn't look that chronic use of immunosuppression did increase the risk of severe COVID-19 disease and possibly was helpful in some cases. But we do know that if you develop the hyperinflammatory syndrome of COVID infection approximately 10 days post-primary infections, then some biologics can improve your outcome. So this is obviously a different mechanism than to the primary infection. This is more of an autoimmune hyperinflammatory syndrome. So we know that dexamethasone that's used at this point can be helpful, and also the IL-6 inhibitors in patients that are who are requiring oxygen therapy, it can be helpful. And there are ongoing studies looking at other biologics, particularly the JAK kinase inhibitors. So if we move on to rituximab, so we already had concerns with rituximab and infections. So we know that B cell depletion with rituximab is long lasting, and that B cells only reach pre-treatment levels at around 9 to 12 months post-treatment. We already knew that there was a significant risk of chronic viral reactivation, particularly hepatitis B virus and JC virus. And it looks like our concerns around rituximab have been borne out. So an observational study in France looking at around 1,000 patients treated with rituximab across all conditions. So these were patients with rheumatoid arthritis, vasculitis, lupus, but also hematological patients who were receiving rituximab for the hematological conditions. Showed that there was an increased risk of severe COVID-19 infection in this group of patients, increased mortality and hospitalizations within 6 months of rituximab use. And this again is a French study just looking at rheumatoid patients, so rheumatology patients. So these are patients with rheumatoid arthritis, vasculitis, and lupus. And what this shows that in the rituximab group, there was a higher instance of moderate or severe disease. Patients had longer hospitalizations, and there was a higher percentage of deaths than in the non-treated group, although this didn't reach significance. But that's probably due to the low numbers of deaths that occurred. So rituximab does look to be of concern with COVID-19 infections. So what about vaccination and COVID and rituximab? So we already know from a number of studies that have looked at influenza and pneumococcal vaccine that vaccine responses are blunted for around 6 months post-rituximab treatment. And there are some studies now showing that immunization with COVID-19 vaccine within 3 months of rituximab is associated with lower antibodies to COVID-19 spike protein, indicating again that there is a lower response to the COVID vaccine. And this is an article that's recently been published in Rheumatology, which is outlining key therapeutic considerations when vaccinated against COVID-19, alongside DMARDs and biologic therapies. So this is not specific to lupus, this is across all rheumatology patients. And the recommendations are that you should avoid vaccination during disease flares. You should taper steroid therapy to less than 10 milligrams daily. You should consider withholding methotrexate for 2 weeks post-vaccination. And you should ideally avoid vaccinating for 6 months post-rituximab. And what it's saying is if you have insufficient time to alter or amend the DMARD or biologic therapy, then you should go ahead with vaccination, but you should assess vaccine response at a later date. And this is really by measuring the spike antibodies to see whether a patient has developed them. So if we go back to Mrs. SM, so she had a number of risk factors for development of severe COVID. She had multi-system lupus, although at the time when she contracted COVID, she had moderate to low disease activity. She did have renal disease. She was on prednisolone, 10 milligrams daily, and she had rituximab. She'd actually had it 7 months prior to the infection, but I'm sure this was a factor in her developing severe disease. She had been vaccinated about COVID, but that had been within 3 months of her rituximab, so it's likely that she had a poor response to her vaccination. So if I knew then what I knew now, what would I have done differently with this patient? So I think I would have considered tacrolimus instead of rituximab because it is not so associated with severe infection. And obviously with the rituximab's long mechanism of action, we had that long period after where she was susceptible. I think I would have tried to reduce her steroid dose faster. So this is always difficult in lupus patients. They feel well on corticosteroids and it is a struggle to get doses down. But in the current landscape with COVID-19, we should all be trying to get steroid doses as low as possible. And she would have received a third primary COVID vaccination. So all clinically vulnerable patients in the UK have been called for a third primary dose of COVID-19 vaccination to try and boost their antibody response. Once she was infected with COVID-19, then we would have checked her COVID-19 spike protein antibodies. We could have, and if they were negative, then we could have considered treatment with Ronaprive. Now, Ronaprive is a newly approved drug for the treatment of antibody negative patients who are clinically vulnerable for COVID-19. This is a combination of 2 monoclonal antibodies that bind to the spike protein on the COVID-19 virus and prevent it entering the host cells. And it has been found to reduce the incidence of severe disease and death in this group of patients. So this would have been a therapeutic option that would have been available to her now. So thank you very much for listening to my talk. I've discussed around a case of a very unfortunate lady who contracted COVID-19 and subsequently died, and then around general infections, and then also COVID-19 in the lupus population. So thank you very much, and I wish you all the best for the rest of the day.
Thank you very much, Doctor, for your very timely topic on SLE and infection. Thank you very much. Now let us move to the next presentation. Next speaker is Dr. Deva Situnayaka, Consultant Rheumatologist and Honorary Senior Clinical Lecturer, University of Birmingham, Academic Department of Rheumatology, Sandwell and Birmingham Hospitals NHS Trust. He is the Clinical Lead, Birmingham National Center of Excellence for Behçet's disease. Over to you, Dr. Situnayaka, to update us on Behçet's disease.
First of all, I must give thanks to the course organisers for inviting me to give this talk entitled Catching Up with the Behçet's Challenge. It's a great privilege to talk to you about an area of my practice I'm so passionate about, and I'm sorry I can't do it in person and that we do not have much more time. First, let me quickly declare my potential conflicts of interest, which are summarised on this slide. So here we see the learning objectives of the talk I give. I hope to achieve this during this talk. I've chosen to avoid case presentations and to focus on the key areas of interest ranging from typical and atypical features through epidemiology and genetics, the ancient origins of the syndrome, and summarising our approach to treatment and how this might develop, hopefully highlighting some important points along the way and stimulating you to read more widely about this fascinating disease that has taught me so much. So, pattern recognition and probability lie at the heart of making a diagnosis of Behçet's, since there is no diagnostic test. Aphthous ulceration is usually the first symptom of Behçet's in most cases. There is then a gap, on average, of 3 to 5 years, but sometimes much longer, before the onset of the second clinical feature. What happens during this period immunologically? We don't know, despite this being a critical issue. There are probably a population of patients, as shown here, with oral ulcers and genital ulcers who are part along this journey, but this is an under-researched area. Here are some of the patterns that we recognise that may be helpful from a diagnostic and prognostic perspective. So we see the male HLA-B51 positive patient with uveitis, usually at the back of the eye, and typically with oral and genital ulcers. Women who present with mouth and genital ulcers and erythema nodosum and arthritis. We also see a male population with mouth and genital ulcers and vascular complications, particularly DVT and vascular arterial involvement, sometimes associated with pulmonary arterial disease. Then we see some atypical cases, such as those of smokers who may have vascular involvement, ocular and neurobehçets or GI features, but there's a systemic onset. And then also we see systemic features in pediatric cases where there may be fever, and this might alert us in the children's population of patients to atypical presentations signaling atypical or monogenic autoinflammatory diseases which might overlap with Behçet's. Throughout all of these subtypes, there may be fatigue, sleep disturbance, and widespread musculoskeletal pain in features typical of fibromyalgia. And curiously, what we observe is that in general, over time and the course of the illness, adults generally get better, rarely presenting after the age of 50 as a new case. And in contrast, children may progress over time. Here we see in the green bubble the 53 million people in England, and I guess in Sri Lanka that will be 22 million. 20% of the population will have aphthous mouth ulcers at some stage, many of them recurrent, and that's a lot of people. At least 90% of patients with Behçet's will have a preceding history of mouth ulcer, just like aphthous ulcers in the 20% of the population, though sometimes they may be more severe and more frequent. We've recently completed and published a study on the epidemiology of Behçet's, which I would encourage you to read. This was based on a primary care database, the THIN network, which established that the prevalence of Behçet's was between 8 and 14 per 100,000 of the population, say about 5 to 6,000 patients in England, though this may be an overestimate as prior studies were 10 times lower than this. So what happens to cause a conversion from a simple oral ulcer to the onset of the second symptoms of Behçet's, usually a GU? And I'm sorry to say that we do not yet have an understanding of the mechanisms for this, though we have some ideas. The triad of genetics, environmental factors and their interaction with probability lie at the heart of this conundrum. We're also able to recognise atypical presentations, and one of the more fascinating findings to emerge from recent research from Turkish cohorts is the role that smoking has in linking to a non-aphthous beginning and a more severe, sometimes systemic onset of disease with vascular and vital organ involvement soon after presentation, and we've observed this in practice in our clinic. Here are the overarching principles from the 2018 Eular Guidance, which are also at the core of the National Behçet's Syndrome Service, which I lead in Birmingham. The Mdt approach to diagnosis is key, gathering together rheumatology, oral medicine and ophthalmology to assess patients with other specialties if required on the day. The goal of treatment is to promptly suppress inflammatory exacerbations and recurrences to prevent irreversible organ damage, which may happen quite quickly in the eye, the brain, the gut, and the vascular system. This also obviously facilitates a far more personalised approach to treatment. This is a forest plot of the prevalence estimates for Behçet's reported by Alfred Marr's group, summarising 45 population-based studies and pooled estimates summarised in our TripAdvisor top 5 spots in the world on the right. Overall, the worldwide prevalence is 10 per 100,000. My estimate for Sri Lanka would be perhaps more aligned to the European numbers, say 5 to 15 per 100,000. we can see a huge variation with greater prevalence along the Silk Route, with prevalence falling 100-fold from east to west. Several studies have shown that for migrants, they adopt an intermediate figure. Not all of this variation can be explained by genetic factors, which are reported to account for up to 16% of the risk. So what does this tell us about possible triggers that might vary across geographies? As we have no diagnostic test, we rely on pattern recognition and probability to guide us, first ruling out all potential mimics or alternative explanations. This is why the Mdt approach is so powerful. Here we see the most commonly used 1990 ISG or Lancet criteria, side by side with the more recently published international classification criteria published in 2014. Both are points-based systems, but we can see that you can fulfill the criteria with oral ulcers and genital aphthosis in the ICBD criteria. Oral ulcers are no longer mandatory in the ICBD criteria. Usefully, vascular and neurological features can now be included as diagnostic features. However, I think that the time element and the way in which combinations of clinical features occurring at the same time or in sequence adds diagnostic weight, and this has not been captured in the traditional classification criteria, and that's where the human comes in, and perhaps AI in the future. So, one of the first things we did in Birmingham was to evaluate the performance of these classification criteria in a UK context, and one might do the same in Sri Lanka. Whilst we found that the new ICBD criteria had enhanced sensitivity, over 90%, we found that it lacked specificity compared to the 1990 criteria, which we now tend to prefer in the UK context, where Behçet syndrome is clearly far less common than in the Middle East. Here we see some of the variable clinical manifestations of Behçet's, and in the second column, how frequent they are, and after that, roughly when they tend to occur. Some of these complications tend to associate with more serious outcomes, as can be seen in the prognosis column. These adverse prognostic complications, such as ocular, vascular, neuro and GI disease, often develop unpredictably and suddenly. Why the disease behaves in this way we still do not know, but note that the GI involvement is more common in Japan and the West than it is in the Middle East. If we delve deeper into Behçet's itself, we also begin to see so-called sub-phenotypes, where, as we previously saw, particular combinations of clinical features tend to cluster together in the same patients. There are 3 or 4 clusters shown here. Extraparenchymal neurological disease is largely venous sinus thrombosis or aseptic meningitis, as opposed to parenchymal disease affecting CNS tissue. It should also be noted that in the Middle Eastern cohorts, ocular disease principally affects the back of the eye, with panuveitis and retinal vasculitis, whilst in Western cohorts we perhaps see less severe anterior uveitis, which is becoming more common. These patterns or sub-phenotypes are increasingly recognised in international studies of cohorts of patients. There is more to be done in this regard in the UK, which the 3 Behçet centres together with my colleague Priyanka Chandrachi will be doing. International work has indicated that there may be an underlying genetic explanation for these observations, linked perhaps to pathways that might be relevant and shared with other immune-mediated inflammatory disease, particularly such as inflammatory bowel disease. And this might be a basis for differing approaches to treatment. Here we can see how some of the combinations of clinical features of Behçet's that we've been discussing can masquerade as other conditions and cluster together. And as we'll hear later, these disease phenotype patterns and overlaps may have an underlying biological basis. I'd particularly point out the arthritis, acne and enthesitis phenotype, which may mimic seronegative spondyloarthropathy patterns that have appeared in some cohorts. The GI Behçet's phenotype, which looks very much like inflammatory bowel disease and sometimes is extremely hard to differentiate from Crohn's disease. And then in children particularly, fever may be a presenting feature, and this may signal possibly autoinflammatory disease-like manifestations of Behçet's disease. And certainly in some the studies that are going on now, we're delving deeper to look at this group of patients, to look for monogenic signals genetically for this type of patient. Inflammation shown on this slide in the endothelium is a key feature of Behçet's disease, which is one of the reasons it's classified as a variable vessel vasculitis in the Chapel Hill nomenclature, and may lead to a variety of features and complications shown here. These often link together and are useful in pattern recognition, so we may see venous thrombotic disease associating with pulmonary arterial, aneurysmal, or systemic arterial vasculitis. The association between thrombotic manifestations in the venous system and arterial or pulmonary vascular lesions is important and known as so-called Hughes-Stevens syndrome. Intuitively, one might think that anticoagulation would be crucial, but as we will see, many studies have failed to demonstrate any added value from anticoagulation compared to immunomodulatory treatment. So in this slide, we see some results from our primary care-based epidemiology study. The one that I mentioned, we'd established an estimate of the prevalence of Behçet's above previously published figures. But the important point on this slide is that we can see that before the diagnosis of Behçet's was made, about 12% of patients had another immune-mediated inflammatory disease. Then went on to a final diagnosis of Behçet's, and a third of those cases were inflammatory bowel disease. A much smaller number went on from a diagnosis of Behçet's to something else again, once again most likely inflammatory bowel disease. Keep this in mind when we begin to explore the genetics more deeply later on. This was a study that I found fascinating, reported in the last ICBD meeting using the Japanese Ministry of Health and Labour Welfare database. These Japanese researchers noted that the sub-phenotypes of Behçet's were changing in proportion significantly over time, with a rise in the GI disease sub-phenotype and a fall in the ocular phenotype. It's interesting to note also that in Japan and Korea, the incidence of Crohn's disease in particular is increasing, perhaps due to a movement to a more westernized diet, and we'll see later how Behçet's and inflammatory bowel disease, especially Crohn's disease, share genetic similarities, which might provide an explanation, since it may be sometimes extremely difficult to differentiate the two conditions. So in summary, we've learned that the clinical presentation of Behçet's is heterogeneous and may vary according to sex, country of origin, and age of onset. So let's now look more closely at the epidemiology and see how this links to the genetics and origins of Behçet's disease. So on this slide, you'll now be familiar with a several 100-fold difference in the prevalence of Behçet's comparing Northern Europe with Turkey. Not all of this variation can be explained by the population frequency of the major risk allele HLA-B51, which mirrors the frequency of Behçet's as it falls from east to west along the Silk Route. The geographic variation of the Behçet's phenotype that we've discussed is debated, but it is interesting to note that in this context, the nature of Behçet's does appear to be changing, especially in Japan, particularly with the GI phenotype increasing and the ocular phenotype decreasing as the worldwide incidence of Crohn's disease increases. As you can see, Sri Lanka is not identified as one of the endemic areas, but it would be of great interest to study the epidemiology, as I don't believe that this has been done. So approximately 130,000 years ago, and possibly at other earlier times, researchers indicated there were more verdant phases in Africa which linked to changes in the natural environment and wildlife, and which triggered migrations of early hominids, including Homo sapiens, who began moving north out of Africa, going east and west and encountering and interbreeding with the more archaic humans, the Neanderthals in Europe and the Denisovans in Eurasia, who may have originated from earlier hominid migratory events from multiple sources in Africa. It's currently thought that a significant chunk of our immune regulatory genes within HLA were acquired from these ancient humans, including HLA-B51. This is something known as intragression between the species. In 2001, Peter Parham's group at Stanford found that some of our HLA has ancient origins from interbreeding with the Neanderthal and Denisovans, and these ancient alleles, including B51, had strong ligands for natural killer receptors. In 2013, Dan Kastner and Elaine Remmer's group in Nature identified that there was an epistatic interaction between B51 and a molecule called ERAP1 on a different chromosome, which is polymorphic, and that trims peptides for antigen presentation on the class 1 molecule, including B51, so selectively shaping the peptidome towards a more loosely bound conformation and suggesting a link with microbial antigen processing and presentation and the regulation of natural killer function. So for Behçet's disease, the class 1 allele B51 and B5 remains one of the tightest known for a polygenic disease genotype, interacting with an odds ratio of nearly 6:1 in meta-analyses. What you may also deduce from this slide is that B51 can serve no useful purpose as a diagnostic test, as 18% of controls overall were B51 positive, and the figure for this is roughly 11% in the UK. Some authors, including McGonigal and Ahmet Gul, have postulated a shared pathogenetic pathway between Behçet's and the spondyloarthritis, with a breakdown in barrier function at mucosal and other surfaces. Research has also shown that there are shared links with psoriasis and inflammatory bowel disease involving the IL-23 receptor and IL-10 polymorphisms. And note that the epistatic ERAP1 reaction operates in different directions for Behçet's disease, psoriasis, and ankylosing spondylitis. So putting this all together, some researchers in the USA have combined all of the genetic studies of Behçet's, performed some additional epigenetic studies, and come up with this graph which summarizes the total genetic risk score and tracks how it varies according to populations. They estimated overall that there was a 16% genetic contribution toward the risk of getting Behçet's, so you could say that a large amount is still unexplained. It also shows by the green line how much can be explained by the known HLA, that's 40%, that's associated with B51. And we can see that the risk is reduced amongst African and African American populations, perhaps because these populations have inherited less ancient DNA from our forebears. I guess Sri Lanka is likely to be intermediate. Here is some more fascinating recent research from some American researchers. They studied the genetics of patients with Behçet's on the one end of the spectrum and simple recurrent aphthous ulcers on the other, and something in between called the FAPA syndrome, periodic fever, aphthous stomatitis, pharyngitis, and cervical adenitis, which is the most common periodic fever syndrome in children. Now it's interesting to note that FAPA shares risk loci for disease at IL-12A, STAT4, IL-10, and CCR1, CCR3 with Behçet's disease and recurrent aphthous stomatitis. And it's the differential HLA associations along this spectrum which were thought to determine where individual phenotypes fall along the spectrum. So these genes might help to determine whether subjects with aphthous disease progress along the spectrum toward Behçet's. We would like to do some research in this area ourselves. So what does this all mean? Well, summarizing it all, knowledge of the genetics has not yet resulted in any major changes to treatment, but we can see that elements of the Behçet's phenotype overlap with some conditions, that these conditions may share genetic similarities, and these particular conditions include Crohn's, inflammatory bowel disease, psoriasis, spondyloarthropathies, and reactive arthritis. It's reasonable to speculate that some of the biology might overlap, and differentiating them clinically might be difficult. It's also interesting to consider that targeted treatments might be used that are based on common pathways which are shared between these conditions. So that neatly moves us on to the treatment, and as we saw earlier, if we delve deeper into Behçet's itself, we also begin to see so-called sub-phenotypes, where, as we previously saw, particular combinations of clinical features tend to cluster together in the same patients. There are 3 or 4 clusters shown here which are increasingly recognised in international studies of cohorts of patients. There is more to be done in this regard in the UK, which the 3 Behçet's disease centres, together with my colleague Priyanka Chandratre, will be doing together. International work has indicated that there may well be an underlying genetic explanation for these observations, linked to pathways that might be relevant and shared with other immune-mediated inflammatory diseases, particularly inflammatory bowel disease, and that this might be a basis for differing approaches to treatment. We don't have time to go through the full Eular Guidance, which has recently been updated, but I would encourage you all to read them, so I've put this on your reading list. So in this slide, we see a summary of some interesting work that was done from an Italian and Turkish group that is based on this concept of a sub-phenotype-based approach to treatment. It's based on a review of the literature and proposes that our treatment pathways should vary for Behçet's, as shown here. For mucocutaneous and articular disease, we would avoid tocilizumab and cycle through colchicine, azathioprine, the anti-TNFs or interferon alpha, then IL-17 and IL-1 blockade. For vascular disease and non-parenchymal CNS disease, including cerebral venous sinus thrombosis, the role of anticoagulants is contentious, but we would use more potent agents up front, including cyclophosphamide for aneurysmal disease, with anti-TNFs as second line. For parenchymal CNS disease and ocular disease, we would avoid cyclosporin A because of a risk of exacerbation of CNS disease, which is established in case reports in the literature, and we would use early steroids and azathioprine and TNF inhibitors up front for resistant or severe disease at presentation, holding tocilizumab for refractory disease, particularly where there is macular edema. Here we see some recent evidence supporting the targeting of IL-17 pathway with secukinumab for mucocutaneous and articular Behçet's. Previous studies, however, led by Andrew Dick's group in Bristol, showed little evidence of efficacy in ocular disease in Behçet's. So we are now exploring a randomized controlled trial of secukinumab for non-ocular Behçet's disease in the UK through the 3 National Behçet's Centres of Excellence, and this work is being led by my colleague in Liverpool, Rob Moots. So here we see some recent data supporting the efficacy of ustekinumab in mucocutaneous Behçet's, an agent that targets IL-12 and IL-23 through the common P40 subunit and works also in Crohn's, psoriasis and psoriatic arthritis. We can see improvement in both number of oral apathy and Behçet's syndrome activity score, so this agent also shows promise for particular subtypes of Behçet's. Here is our current Behçet's disease drug pathway, which you will be able to find on our National Centre of Excellence website if you Google it. We step up from less complex mucocutaneous disease through ocular to severe systemic disease, and pretty much our pathway reflects the Eular Guidance. More recently, however, we have made a proposal which we have put before our commissioners for an evolution of this pathway towards a more sub-phenotype-based approach. The current pathway has always used an approach varied by phenotype, but now we've extended this further, pretty much in line with the Italian and Turkish authors' work shown on the previous slide. As international evidence now suggests, evolving further to a more individualized sub-phenotype-based approach is appropriate. In this evolution of our pathway, the choices for the first and second line therapeutic agents will continue to be based on the current Eular Guidance and the principles underpinning our current treatment pathway. Anti-TNF therapy will remain the first choice for treatment of refractory disease or treatment intolerant, or for those with poor prognostic features at presentation. However, where such approaches fail in approximately 20% of cases who commence anti-TNF therapy, a more tailored sub-phenotype-based approach would be recommended, depending on the disease subtype. In other words, we would perhaps switch to another class of biologic agent depending on the subphenotype. So from multiple studies from all over the world, we've learned that our Behçet's disease constructs are not necessarily homogeneous entities, and that from a therapeutic and outcome perspective, functional pathways and their relative dominance within phenotypic clusters within Behçet's are more likely important. We do not yet have any reliable prediction signatures to help us diagnose, predict outcome, or response to treatment, but this is likely to come through the study of metabolomic and epigenomic and genetic markers, and there are some promising data emerging internationally on this. So what about the atypical cases that I mentioned in my earlier slides, particularly in children? Those that have a family history, or perhaps a history of fever or systemic onset, or those where there's consanguinity in the family, particularly in paediatrics. How do we spot these cases genetically? Well, what this slide shows is that for alleles with a frequency of less than 5% in the normal population, GWAS studies are unlikely to be helpful in picking up these signals. And next-generation high-throughput sequencing and whole exome sequencing, and used in a targeted way, particularly where there are familial cases, is useful and informative. And through these sorts of approaches, subgroups with atypical features have now been found with evidence of monogenic autoinflammatory involvement at the genetic level. So this approach would pick out rare variants of small effect size that are very hard to identify through GWAS studies. We're collaborating on this, particularly with our childhood cohorts at the Birmingham Children's Hospital with Paul Grogan's team at Great Ormond Street. So I will end my presentation with two slides, first with Paul Brogan's work using this technology. His team have recently published a series of 11 paediatric cases with atypical features, at least 9 of whom turned out to have definite monogenic mimics of the Behçet's phenotype. So as the authors say, there is clearly more work to be done in this area, both in the paediatric population with Behçet's and in other adults. So watch out particularly for these cases who have disease onset below the age of 5, where there is a family history or a history of consanguinity or an atypical course. This slide essentially shows some of this type of work done recently and reported in Nature from a Spanish group using next-generation sequencing to look at the frequency of rare polymorphisms for the known variants in 7 inflammasome-related genes associated with known autoinflammatory diseases. You can see that they were found frequently in 355 Spanish Behçet's patients in this study. 62 mutations were found among the 355 Spanish patients with Behçet's, and at least 38 of them were potentially pathogenic. This once again suggests that rare mutations in the inflammasome pathway may be more common amongst Behçet's patients. So as we mentioned, we're likely to see more of this type of work emerging in the future, and I know that Paul Brogan's team is leading this. So in conclusion, the MDT approach is a key design principle to aid treatment decisions and diagnosis in Behçet's disease. We must think of Behçet's as a construct with complexity in biology and overlap with other immune-mediated inflammatory diseases, as seen in practice in our GP-thin study. Clustering of phenotypic elements in time and in sequence may aid treatment decisions, and this is something that humans can do, and perhaps AI can do as well in the future. Highly targeted biologics unravel the biology, so it's important to keep curious for subpopulations of patients who don't respond in the typical way. Finally, we must remain vigilant for atypical features which might signal monogenic mimics of Behçet's, particularly those under the age of 5 or with a family history, and particularly in paediatric presentations. The diagnostic journey to Behçet's frequently includes alternative immune-mediated inflammatory diseases with overlapping phenotype and biology. particularly inflammatory bowel disease in a third of such cases where clinical differentiation may be challenging. Common underlying susceptibility genes may underpin this phenomenon, and there's much more work to be done on this in the future. The overlap with inflammatory bowel disease might also account for some of the higher prevalence of Behçet's that we have observed in our primary care database studies in England, and Priyanka and my team in Birmingham are exploring this further in further epidemiological studies. Finally, I'd like to thank my colleagues, many of whom are highlighted on this slide, without whom I wouldn't have got my thoughts together about this condition, and we wouldn't have done much of the research work, some of which I've published in this presentation. So I will finish on this slide, which summarises some of the future challenges to be addressed in the Behçet's field. I'm so grateful for the opportunity to deliver this talk and hope that one day I'll be able to do so in person, perhaps with the results of our more recent studies. I would be happy to address any questions if there is time.
Thank you very much, Dr. Devasittanayake, for this very informative presentation. And I would like to thank all four speakers, Dr. Kalundeshapriya, Dr. Srinivasan Venkatachala, Dr. Nicola Urban, Dr. Devasittanayake, all for spending their valuable time on updating us. Thank you.
The next is, we'll start with the Q&A session. And first of all, I must thank all the four speakers joining live with us today. And the first question is to Dr. Kalundeshapriya. And the question is there any evidence to say that increased awareness or improved diagnostic was able to bring down the diagnostic delay?
Okay, right. Thank you very much for that question. Yeah, actually, I have not included these details in my presentation due to time factor. This area of new interest, actually, very few papers are coming up with regard to the diagnostic delay. Even in the published data in the recent past, the results are actually divided. So in some part of the world, the results show there is probably very minimal meaningful reduction in the diagnostic delay. For example, in studies or papers published in the recent past in studies done in UK and German and in France, and there had been minimal evidence to say that now the diagnostic delay had been delayed. Has been able to shorten, but in there are some other parts of the world, for example in Japan, and especially one large study done in Denmark has shown a remarkable reduction in the diagnostic delay, and they are now talking about the diagnostic delay in months, and that is the only study that has shown such an improvement. But most of the other studies has shown some improvement, but the tendency now is that over the years, with the advancement of the diagnostics and the awareness of the diagnostic classification criteria and spondyloarthritis features, there's a tendency that the diagnostic delay had been able to reduce. Yes, the answer is there are some evidence to say that now this delay has been able to reduced, but this is a new area and not very many published papers.
Thank you, Dr. Kalum. And this question, we received a few questions. And this question to Dr. Srinivasan. Since treatment for osteoporosis does not immediately provide patients with any symptomatic relief, do you feel that compliance is an issue in the NHS UK?
I think that's a good question, but this is a problem treating any chronic asymptomatic disease like hypertension and other things. If people don't have any symptoms, they don't see the value of taking a treatment so long with side effects and complex things. So that's where the compliance comes in. But if you catch them early when they've had a fracture and they're still in pain, and tell them the importance of treatment and to prevent future fractures, as they do with hypertension to prevent strokes or heart attacks later. So this will be valuable. But I think use sort of parenteral therapies where you have an opportunity. So we have 1,500 patients on intravenous zolidinate in our unit because the compliance is 100%.
Yes, thank you, Dr. Srinivasan. And the next question to Dr. Nicola. And the question is there a special mechanism within NHS to monitor pregnant lupus patients, especially during the COVID pandemic?
Well, there isn't a particular mechanism across the whole of the NHS for lupus patients who are pregnant. So different units will have different structural organisation. So in my unit, I send my lupus patients to a specialist clinic up in Birmingham that deals with all types of immunological disease during pregnancy, and they have very close follow-up there. So I tend to alternate my follow-up with that unit. So they'll be seen there once and then they'll be seen with me. But obviously during the COVID pandemic, we've also tried to limit the number of appointments patients physically come to hospital because of the risk of contracting COVID-19 by attending a healthcare setting. So we do have close follow-up of them, but there isn't a formalised follow-up throughout the UK. It tends to be on each individual unit. Thank you.
Thank you. And the last question, this is to Dr. Deva. Is there data to suggest that a significant proportion of Bisphos disease patients are seen by doctors of other specialties, especially as it has some unusual extra-articular manifestations?
Absolutely, that is correct. But obviously, because of the nature of Behçet's disease, it can present to many other physicians. And just like the other speakers have indicated, the time to diagnosis is very often delayed. And certainly before the setting up of the National Centres of Excellence, the average time to diagnosis for Behçet's in England was over 11 years. That's fallen now to about 6 years through the monitoring of the data that we've had from the centres. But we see patients often presenting to gynecologists, to the STD clinics, and to dermatologists most commonly, but also often acutely to the neurologists and the gastroenterologists. So part of our national pathway is that patients can access the Behçet centres either directly for a physical consultation or virtually with a telephone conversation with these other clinicians to facilitate diagnosis at the acute stage. And we've certainly learned how that can be beneficial as a result of the COVID pandemic. So I think as Nikki Erb was saying, I think that the COVID situation has probably transformed the way that we have practiced healthcare in the UK, and it's unlikely to go back to the way that we did it before. And that may have some benefits for our pathways for diagnosis, particularly for these complex patients.
Yeah, thank you so much. And so those are the 4 questions that we received from our Q&A sessions. And as you know that this is the month of rheumatology, and I would like to thank Dr. Monica De Silva, the President of the College of Specialists in Rheumatology and Rehabilitation, Sri Lanka, and all the college members to have a collaborative work with the Ceylon College of Physicians, and also sharing this session with Professor Senaka Rajapaksha, the President of the Ceylon College of Physicians. And I would like to thank especially to Dr. Himanta Tukwarala, who is the coordinator in our council for this College of Rheumatologists. And also, finally, all the members who joined online. This is a fully virtual specialty update. And so this is the final event that we had with the College of Rheumatologists, basically in Rheumatology and Rehabilitation Sri Lanka. And I would like to thank the audiovisual team as well. And I wish that you are going to start your annual academic sessions starting from today onwards and for next 2 days. So wish you all the best. Thank you so much.
Thank you.